I welcome everybody. My name is Harvey Ryder, and I'm here on behalf of the sponsoring groups for this next in our series of brown bag programs. The American Jewish Committee, the Jewish Community Relations Council of Greater Washington, Tzedek, DC, two representatives right here, and Jewish Federation of Greater Washington. So I want to thank everybody for joining us today. We're going to be talking about a very important issue, the mental and financial burdens of medical debt and the tremendous impact that has on people's lives and all the great work that Tzedek DC has been doing on it. You have the bios for our two speakers, Ariel Levinson-Waldman, who is the director of Tzedek DC, and Jennifer Holloway, who is an intern. What would be the formal title?
Equal Justice Work Fellow.
Oh yeah, Equal Justice Work. And before she speaks about the substance, I think it would be great if Jennifer talks a little bit about Equal Justice Works and the important work they do to provide support for lots of nonprofit organizations.
Sure.
So I'm going to step off camera and leave it to our two speakers to talk. And I think there'll be a PowerPoint too. So we'll just give us a signal when you want to go to the next page.
Thank you, Harvey. So I'm Ariel Levinson-Waldman, and my job here is brief but really pleasant. It's number one to say thank you to Harvey and Vicki Fishman and all of our partners at JCRC. It's been a terrific partnership. I think now going into year 7 for us at Tzedek DC. Number two, a very brief overview on our work at Tzedek DC. And number 3, to introduce my fantastic colleague, Jennifer Holloway, who is in fact the Equal Justice Works Fellow at Tzedek DC. Tzedek is this beautiful word from Deuteronomy, meaning justice or righteousness. And so our name flows from this, Tzedek, Tzedek, Tirdof, justice, justice, shall you. And the command is to all of us, shall you pursue. Our particular mission at Tzedek DC is to safeguard the legal rights and financial health of DC residents with lower incomes who are facing debt, credit, debt collection, and other forms of consumer or financial use challenges. We do this work, and you'll hear a lot about it in the context of medical debt, where you really see some of the worst applications of this problem. We do this work as racial justice work and through a racial justice lens for 2 main reasons. One, because of centuries, decades, including ongoing practices in some quarters of our government and some quarters of corporate life. The wealth gap, statistically speaking, tracks race. What does that look like? In the District of Columbia, the statistically typical white household has wealth as defined by net assets that are 8,100% that of the statistically typical Black neighbor. And every time I think about that number, I think that the comma must be in the wrong place, but it's not. And so that's our baseline when it comes to policies that turn on whether somebody has enough money to make a payment. Number 2, we are up against a series of systems in the private debt collection market and in the public fines and fees enforcement context, which weaponize both the courts and some governmental coercion tactics and have the impact of disproportionately extracting wealth from brown and Black households in DC and Maryland and Virginia and throughout the country. So that's who we are. That's our mission. That's why we pursue it. In support of that mission, we do 3 things. Number 1, we provide free direct services to those who are eligible. And that's a pretty broad group. If you're a family of 4 and you make anywhere under $120,000 a year, you're eligible for our services. Those free services include 2 main things: free legal help in the context that I was describing, and financial counseling. Number 2, we do systemic work. You'll hear a lot today from Jennifer about the systemic challenges and opportunities we have when it comes to medical debt. And so that's changing the rules in the DC Council. We've done some work on other issues in Maryland, occasionally in Virginia. We also work with agencies and in coalition, both in DC and nationally. We've done some work for Congress. We've also done things like represented by Harvey and colleagues at Stinson in partnership with the JCRC, challenging some of the worst federal policies. For example, the successful effort to roll back the Trump administration's public charge rule. So the second bucket of our work is policy. And the third is community outreach and education, which is led by our colleagues, Stephen Jefferson and Naomi Ajala. This is done in English and Spanish, and over time, we're looking to expand our work in Amharic, French, Chinese, the 5 most common languages of the 100+ languages spoken in DC. The theory here being knowledge and rights are only as good as the extent to which community members know about what those rights are and what to do and where to go to vindicate them. Before the pandemic, medical debt was a big deal. Coming out of the pandemic, medical debt, biggest category of debt in collection in the United States, a huge deal. We feel so strongly about it that we recruited an incredibly talented and experienced lawyer to do nothing but medical debt, at least in her first 2 years with us. And Jennifer Holloway is our Equal Justice Works Fellow at Tzedek, DC. Before law school, Jennifer completed a master's in social work. And so really comes at this in such an exciting way with a systems viewpoint. Had a terrific record in law school, time spent in other states' attorneys general's offices. And we recruited Jennifer to join this past fall on a fellowship that is underwritten by PayPal and by the Orrick law firm, which I think gives a sense of how broadly understood some of the injustices in the medical debt context are, that you have some major corporations and attached law firms willing to commit time and resources to bring in talent to address this issue. So I'm going to turn things over to Jennifer and thank Jennifer in advance for today's work and for everything else you're doing.
Thank you. I can give a quick brief overview about Equal Justice Works before I get into the meat of the presentation. Equal Justice Works is a nonprofit that acts as an intermediary between the private philanthropy world and for-profit world and the nonprofit world. And they help match people who are interested in funding fellows like myself with the fellows. And so a fellowship is a 2-year project-based position, and the Equal Justice Works gets private dollars to fund your salary. So my salary is completely paid for by PayPal and Orrick, like Ariel mentioned, but Tzedek DC is the beneficiary of the work, which is awesome. And they have over 80 fellows each year across the country doing different project-based work. And my project is medical debt, like I talked about. So let's get into it. You can actually skip to slide 10 of the presentation. Sure.
Let's see, I probably
Perfect.
There it's
Yeah.
there.
You're seeing it? Oh,
Yeah. So
wait, do I need to share, like, if my camera's off, does that have an impact, or do we know that people can see it?
I think they can see it.
Okay.
Can we get some feedback from the virtual room? Can people see the
Yes.
PowerPoint?
perfect.
Great, okay.
Thank
So
you.
you said to 10?
Yeah. It's a presentation overview. The first couple slides are just what Ariel talked about our mission and our services. So great. So in this presentation, I'll first start by talking about the scope of medical debt, and then the impact, and then some steps to address medical debt. Next slide, please. So the scope of medical debt. What does medical debt look like across the country? So across the US, about 100 million Americans have medical debt currently. In DC, about 90,000 residents have medical debt, and about 40,000 of those residents are facing a medical debt in active collections. And in Maryland, about 600,000 Maryland residents have medical debt currently. Medical debt can affect anyone, regardless of age, race or ethnicity, or income level. But people aged 30 to 64 are more likely to have medical debt, And then people of color are also significantly more likely to have medical debt, which I'll talk about a little more in a minute. Next slide. So what does medical debt look like? There's a lot of different ways that medical debt can show up. So most frequently we think of people having bills that are overdue or that they can't afford. That's definitely one way it looks, but medical debt can show up in a couple other ways as well. So for example, people could have a payment plan with a medical provider. So they're paying a monthly or weekly payment amount to the provider to slowly work down their bill. They could also owe a bank or a collection agency or some other lender for the medical debt. They could have medical debt on a credit card that they're trying to pay off over time, or they could owe a family member. So they could have borrowed money from a family member or a friend to pay for their medical care, and now they're trying to pay that back. Next slide, please. Medical debt is a big racial justice issue. So across the country, people of color are significantly more likely to hold medical debt, and Black people specifically are 3 times more likely to be sued over debt than white people. So in DC, people of color are 3 times more likely to have a medical debt in collections than their white counterparts. And in Maryland, there's also a big racial disparity as well. Not only are they more likely to have medical debt, they're also more likely to have a higher amount of medical debt. So people of color owe more in medical debt than white people across the country. And further, people of color, both in DC and Maryland and nationally, are less likely to have health insurance. So since they're more likely to be uninsured, that plays into why they're more likely to have medical debt and to have higher rates of medical debt. Medical debt is also a big disability justice issue. So interestingly, having insurance is actually not a very strong predictor of having medical debt. And that's because even with insurance, people often have copays, deductibles, and co-insurances that are more than they can afford. Actually, chronic illness is a much stronger predictor of medical debt. And that makes sense if you think about it, right? Like if you have a chronic illness, you're going to the doctor more frequently, you need higher rates of care, perhaps more medicines or more surgeries, and you're just utilizing healthcare much more frequently because of your chronic illnesses. And so those bills just really add up in a way that makes it much more likely for you to have medical debt. So also adults with disabilities are twice as likely to have medical debt. And in populations where we have more people with chronic illnesses, we see much higher rates of medical debt. And so in the South particularly, there's really high rates of medical debt, and that's both because there's more people of color and because there's higher rates of chronic illnesses. Next slide. Okay, so what does the impact of medical debt look like? We all know that medical debt's bad, but what does it really mean when someone has medical debt? Like, what are they giving up? What's the burden on them? So this graph is from a study by the Kaiser Family Foundation. They asked people whether or not they had medical debt, and then if they did, they asked what they sacrificed because of that medical debt. So as you can see, 63% of all respondents cut spending on food, clothing, and other basic necessities because of their medical debt. Almost half of all people used up all or most of their savings because of the medical debt. Other people took on extra work. They delayed getting a home or an education. They changed their living situation. They sought aid from a charity or a nonprofit. And 17% of all people declared bankruptcy or lost their home because of medical debt. Next slide, please. So specifically, what's the financial impact of medical debt? Medical debt is the leading cause of bankruptcy in the United States. So out of everyone who declared bankruptcy in the US, the majority of those people did so because of their medical debt. Medical debt also increases your likelihood of being sued. That's either by the healthcare provider or by a debt collector once a healthcare provider has turned over your debt to the collection agency. And like I said previously, people of color are 3 times more likely to be sued over debt that they owe. Medical debt also really impacts one's ability to pay their other bills. Like I just said, people have to decide what they're going to spend their money on, and medical debt is an added burden on them. So they're deciding, am I spending my money on food, utilities, or am I trying to pay off my medical bills this year? And it's just a really hard balancing act that a lot of people have to take into consideration. And relatedly, medical debt increases the use of high cost loans, for example, payday loans, and that's in part because you have just more bills that you're struggling to pay. One thing I'll add is medical credit cards are a related financial burden on some people. So a medical credit card is a credit card that is targeted to patients directly at a healthcare provider's office, and it's shown as a way for people to immediately pay bills that they might not otherwise be able to afford. And when they first take out the credit card, it has a 0% interest rate, which is targeted as great. However, what many patients don't understand or aren't told about is that medical credit cards have really high rates of deferred interest. So most of the time, patients who take out a medical credit card aren't able to pay off their bills within the time limit with the 0 interest, and then they're hit with these super high rates of deferred interest. And across the country, Americans have actually spent $1 billion in deferred interest on medical credit cards. Next slide. A huge financial impact of medical debt is when it comes to credit reports. So having medical debt on your credit report can impact your access to jobs, housing, and other lines of credit. Medical debt shows up as negative accounts on your credit report, and this means that some housing providers won't rent to you, some jobs will turn you down. It's really difficult for people to get mortgages, or when they do, they're on much more unfavorable terms. And similarly, it's hard to access other lines of credit. And medical debt is not really correlated at all with creditworthiness. Actually, the CFPB has recently done some studies that found this, because when you get into medical debt, it's because you got sick. You have no control over it, and so it's not related to creditworthiness, yet it continues to have these negative impacts on your credit report and all the related financial terms. Next slide. Fortunately, there are some improvements that are being made related to medical debt on credit reports. The 3 major credit reporting agencies have all voluntarily agreed to do a couple things. First, they have removed all paid medical debt from credit reports. Second, they are delaying reporting medical debt on credit reports until a year after they're due. And third, they've removed all medical debt accounts under $500 from credit reports. This is awesome, but there's 2 main barriers. So the first is that these are just voluntary agreements. The credit reporting agencies just decided to do this. And so there's still the threat that at any time they could reverse this policy and start reporting medical debt again. So we really need some congressional action or action from the CFPB to enforce this and make sure it's a permanent change. And second, removing medical debt under $500 is a great step, but it's just not enough. We really need to remove all medical debt from credit reports. So after medical debt below $500 were removed from credit reports, that took out about 50% of all medical debts on credit reports. So about 50% fewer people have any medical debt on a credit report, which is great. But there's still over 22 million people who have a medical debt remaining on their credit report, even after this change. Next slide. So medical debt also has really significant mental health impacts on patients. 4 in 10 Americans have said that they're more afraid of going into medical debt than of getting a serious illness itself. Medical debt is highly correlated with higher rates of anxiety and depression, and having debt in general leads to much higher rates of suicide. And medical debt is just a constant mental toll on people. Like we talked about before, all the financial impacts take a really significant toll on their mental health. They're worried about whatever physical condition they had as well. And so it just really has a really big mental health impact on patients. Next slide. Relatedly, there's a big physical health impact on patients as well, actually. 1 in 3 families report that they've delayed medical treatment because of the cost. So people are actively avoiding seeking healthcare because of the cost of care and because they're in medical debt. People also don't fill their prescriptions because they're not able to. We hear about people rationing their medications, which just leads to worse physical health overall. And even if people want to access healthcare, their medical debt is actually an obstacle to doing so. There's a recent article in the New York Times talking about a nonprofit hospital system that has an explicit policy of denying care to patients who owe them medical debt. even if people overcome all these barriers and want to go access medical care, they're turned away from doing so because they owe the provider care. Even in hospital systems that don't have an explicit policy, we hear countless patient stories of people who have been turned away from hospitals across the country because they owe bills to their providers. Next. So one thing that healthcare providers can do to help mitigate medical debt is providing financial assistance. It's colloquially known as charity care. So charity care it's financial assistance that the healthcare provider provides to the patient to lower the cost of their bill. So they're lowering the out-of-pocket costs that the patient has to provide, so they're less likely to have to go into medical debt to pay it off, which is great in theory, but unfortunately, there's a lot of issues in practice. Oftentimes, patients aren't aware that financial assistance exists and it's available, or that they're eligible for it. And there was a recent New York Times expose about the Providence healthcare system. It used to operate in DC, no longer does, mostly on the West Coast now. But Providence actually paid McKinsey Consulting $45 million to come up with a system to wring money out of patients. So they came up with this explicit policy called Rev Up, which stands for Revenue Up, and it was a way to keep patients ignorant of the availability of financial assistance. So they'd ask patients to pay regardless of whether they were eligible for financial assistance. They specifically were told not to tell patients about the availability of financial assistance, all of these things. And as a result, hundreds, if not thousands of patients have medical debt now that they never should have had in the first place because they were eligible for financial assistance and should have had their bills lowered by the hospital. Next slide. So what can we all do about medical debt? I'll talk about three main things: education, legislative advocacy, and the purchase and cancellation of medical debt. Next slide, please. So first, in terms of education, educating ourselves is just a really great first step. Learning more about what medical debt looks like, who it impacts, all of these things is just a good first step. So these are a few resources. The first, Diagnosis Debt, is this in-depth investigative series by Kaiser Health News and NPR. There's a study on the scope of medical debt and the impact, what states and localities are doing across the country to address medical debt. And they also have a lot of interviews with individuals who have medical debt, talking about why they went to the hospital or the doctor and what the impact of medical debt has been on them. There's also a study talking about how medical debt is a social determinant of health in a research article that's really a great read. The CFPB has numerous reports on their website related to medical debt. They have some about the impact of medical credit cards. They have them on medical debt and creditworthiness, all those types of things. There's also a couple really great reads on the racial impact and racial disparities with medical debt. So, for example, the National Consumer Law Center has their report, The Racial Health and Wealth Gap, that looks at the impact of medical debt on Black families specifically. And relatedly, Brookings Institute has an article on the racial implications of medical debt. Both really great reads. Relatedly, you can learn more about REP medical debt. I'll talk more about them later, but REP is a nonprofit that purchases and cancels medical debt for free for patients. So they're doing some great stuff. We're partnering with them in DC, which I'll talk about. But you can read more about them on their website and learn more about the work they're doing. And a lot of private groups, including like churches and other congregations, have partnered with them to start their own fundraising campaigns to purchase and cancel medical debt. And there's numerous news articles talking about their work as well. Next slide, please. Okay, in terms of federal legislative advocacy, we are really happy that the Biden administration has actually made medical debt one of their priorities. And so the administration itself is trying to do a lot to address medical debt. For example, Biden has directed the Department of Health and Human Services to evaluate how healthcare providers' billing practices impact access and affordability of healthcare. They are also providing guidance to all agencies to eliminate medical debt in underwriting for any credit programs. And the Veterans Administration is making it easier for veterans to get their medical debt canceled. And they've largely stopped reporting medical debt to credit reporting agencies. Next slide, please. Which is awesome, but there's still a lot of work to do. Medicare for all would obviously be the best step to eliminate medical debt moving forward, but there's other stuff that we can do in the interim to help eliminate and alleviate medical debt. So at Tzedek, we have been partnering with Our Revolution, which is a progressive nonprofit grassroots advocacy campaign. And with them, we have met with staff members from Bernie Sanders' office and Ro Khanna's office to talk about a bill that they are proposing shortly that would help. It's geared toward limiting collections on medical debt, which is great. We're also working with their offices to help urge some more executive action. We are really interested in seeing if the Centers for Medicare and Medicaid Services could do more rulemaking to improve financial assistance policies across the variety of hospitals. Next, please. And then there's a lot we can do on the local level as well. So as some of you may have heard, Mayor Bowser recently announced a grant of $900,000 to purchase and cancel medical debt. So medical debt can be purchased for pennies on the dollar, which is a great investment. And so this $900,000 grant will be able to purchase and cancel about $80 million in medical debt. And this is going to eliminate all the medical debt for about 30,000 district residents. And at Tzedek DC, we did a lot of the background work to get this to happen. We met with Deputy Mayor of Health and Human Services team. We wrote a letter to the mayor, met with staffers, all these things to help get this through the door. And we're really excited she did it. And RIP recently, last week, actually won the grant. And so they are now in the process of connecting with hospitals and all the healthcare providers in the district to help to get them on board so they can start purchasing and canceling the medical debt for district residents. Unfortunately, this couldn't happen in Maryland right now. Maryland actually has a law that prohibits the sale of medical debt completely. So that law would have to be amended to create some sort of carve out for nonprofits to for hospitals to be able to sell their medical debt to nonprofits like RIP in order for it to be purchased and canceled like we're doing in DC. And purchasing and canceling is medical debt is great, but we really also know that we have to stop people from accruing medical debt in the future. We don't want to have to go back to the government every year asking for more funding. We really need to do more to stop people from getting medical debt in the first place. So in DC, we're really interested in pursuing policies to help strengthen the financial assistance requirements for healthcare providers and also help end abusive debt collections related to medical debt. States across the country have a lot stronger state-level policies to address medical debt than DC does. And so we're really using a lot of those as examples for what we can do in DC. And as you may know, DC recently updated its debt collection law for the first time in decades, and medical debt is now included under that law, which is great. But there's still more work we can do, for example, around debt relief from nursing homes. Next slide, please. And so the last action item I'll talk about is purchase and cancellation of medical debt. So RIP medical debt, if I've mentioned, is really the main player in this space. So they act as a third-party debt collector, except instead of trying to collect on the debt, they simply cancel it. And so they'll purchase debt from either other debt collectors or from healthcare providers directly. They purchase debt for patients who make up to 400% of the federal poverty level or whose medical debt is 5% or more of their annual income. There is no application process. So once they have the funds, they will work in a specific geographic area to purchase and cancel debt, and no one has to apply. They will let the patients know that their debt has been canceled via a letter, and then importantly, they'll remove the medical debt from their credit reports. So it's no longer having any lasting financial impact on the patients once it's removed. And like I said, it can be purchased for pennies on the dollar, so it's a really great investment. Other localities across the country have similarly decided to use government funding for the purchase and cancellation of medical debt. For example, Cook County, Illinois, Toledo, Ohio, New Orleans, and Pittsburgh have all committed to government funding for a large-scale purchase and cancellation of medical debt. But even before that, they partnered with individuals and a lot of churches and other congregations actually to purchase and cancel medical debt. Next slide, please. So I'll talk about this in the form of reparations, actually. A lot of congregations have started campaigns with RIP as part of their work on reparations. For example, they'll do some readings about systemic racism and the lasting impacts, specifically around finances that it has on Black people, and then they'll start a fundraising campaign in their area. And RIP can use specific data to target specific zip codes. And so you're really able to target the areas with the highest need that you're interested in serving and to purchase and cancel their medical debt. A lot of people are viewing this as a form of reparations by purchasing and canceling medical debt for specific zip codes with high populations of people of color. And that's what I have. I'm happy to answer any questions or facilitate further discussion.
Thank you, Jennifer.
Yeah.
I want to echo everything that Jennifer said, and I want to add in sort of a through line from a Jewish perspective very briefly, which is these concepts of economic dignity for debtors go very deep in Jewish tradition. And so we have Torah and Mishnah that give us guidance on the imperatives for a creditor to keep in mind the dignity of the debtor. And for example, for 3,000 years, it's been teachings that whatever the recovery from the debtor occurs, that at least a year of clothes and a certain amount of food and barley, and in the teachings, the prayer shawl could not be taken away. And this has very much 21st century implications and connections, because what we're talking about here is a system that deprives, as Jennifer so vividly illustrated, debtors, particularly in this context, medical debt holders, from both the dignity of health, because as we heard, we see reduced or abandoned efforts to seek healthcare, and the dignity of financial stability as people's all important credit reports are tanked and access to loans and rental housing approval. And in many cases, jobs, 1/3 of jobs in the DMV requires a background report that entails a credit check. And so that's one strand of a connection to deep Jewish traditions I want to lift up. And I just briefly wanted to note, Jennifer made reference to congregations banding together to purchase and forgive medical. RIP calls this the church model, because in a lot of places, it's the churches that do it. But there's an emerging trend. Chicago is a great example. We've had conversations with Chicago about churches and synagogues partnering to bring resources of their memberships together to engage in this community investment of removing medical debt from neighbors' burdens. There are some preliminary activities in the DMV to bring synagogues and temples into partnership with each other and with RIP, but also with churches. And so I want to echo everything Jennifer said, and also just put a Jewish exclamation point on this topic and on this work. And Harvey, Vicky, anything you want to add or raise as we open things up?
Yeah, I had a few questions. One thing it's not really a question, but I wondered if Ariel and Jennifer, you could talk a little bit about the background of Tzedek's involvement in the RIP type programs and what prompted that and what things you've done, just to describe your work in this area.
Sure. Why don't I do the first half of this, and Jennifer take us from starting about a year ago.
Sounds great.
As we talked about at the beginning, medical debt has been a big problem for a long time. And even before the pandemic, which really laid into stark relief the extent to which wealth is health, the extent to which our systems, and including our medical systems, lay bare the massive race disparities and impact. Medical debt's been a big deal for a while. And so RIP was created about six and a half years ago. And it's a nonprofit, a national nonprofit, they're headquartered in New York. And their sole mission, laser focus, is to engage in this practice that Jennifer described of bringing private and public dollars to bear to purchase written off medical debt accounts at something like a penny on the dollar, because the hospitals have already tried to collect and have already gotten the accounting benefit of a write-off. And then to engage in this very important step, as Jennifer was describing to us, of taking the debt, canceling and taking it off the credit report. So this was on our radar as one of a number of important tools that should be considered when thinking about how to, at the individual and systemic level, address medical debt. This is pre-pandemic. So we had been doing, work in the courts and seeing some really concerning cases where we took on clients in these cases where hospitals had sued patients who should have been entitled to zero bills because they were their income and put them as eligible for charity care. But there was a breakdown in the process, either because, as Jennifer was teaching us, the information was affirmatively suppressed, or something didn't work out in the application, but they were nonetheless billed, and then they were debt collected against and then sued. So we looked at this and said, well, this reflects some major breakdown in the process. So we looked at the individual cases. We looked at the need to change the rules. That led to what Jennifer was describing before, the first ever affirmative, clear location of medical debt as within the scope of DC's debt collection laws. And then we learned about RIP, which is such an interesting, provocative, and powerful parallel strategy because it's a quasi-market strategy. And we began conversations with RIP about our systemic work and about their philanthropic market-based work. And right around that time, somebody reached out to us and said, I am committed to bringing my philanthropy to focus on direct investments. And what I would like to do is help DC residents get rid of their medical debt. And I understand you guys are looking at that issue. And that focused our attention. And over time, with the benefit of some incredibly helpful pro bono legal advice from places like Stinson and others, we satisfied ourselves that this was 100% lawful and a good thing to do, both from the tax perspective of the patient and good and healthy for the hospital. And so we were able to bring that philanthropist into partnership with RIP on a pilot basis almost 5 years ago and relieve the medical debt of 268 DC families in 90+% Black zip codes and see the impact, the real impact albeit a modest volume. And that set us up when we got into the pandemic and we're thinking about how to grow this work. That set us up to engage with RIP at the next level. And I'll turn it over to Jennifer to carry forward the movie.
Sure. So we've been working with RIP for a long time. I started this past September, and we've been having regular meetings with them ever since. So we talked with Deputy Mayor Turnage. He is the Deputy Mayor of Health and Human Services in DC, and he's also the Director of Healthcare Finance. And we talked to him about the issue, provided a lot of background information about the problem of medical debt in DC and RIP's model, and how in DC, we could follow these other localities to use government funding to purchase and cancel medical debt. And he's been a great partner, luckily really on board, really enthusiastic about this whole work. And so we wrote a letter to the mayor that he passed on to her describing this issue and the potential for investment again. We talked to him numerous times, met with other staffers in their office to talk about the issue, and then the mayor was interested, luckily. We had initially proposed that she use budget, she put it in her 2024 budget, but that budget was a lot smaller than everyone anticipated. And it turned out she had some surplus funds left from fiscal year 23 and was really interested in using those funds for this project. And here we are now. So like I said, RIP just got the grant last week. So early stages of their conversations with hospitals. We're really hopeful to get all those, they need to get their business agreement or purchase agreement signed by the end of September, just under GC policy. So quick turnaround to do so, but we're hopeful that it'll all work out quickly and we'll have some good stories to share in the fall.
For any of you who are outside counsel to hospitals, this is a good time to whisper in their ear.
So I have a few more. I know we want to open up questions from the audience, but I did have a few, especially from your presentation, Jennifer. So one of the first ones that occurred to me was when you talked about how hospitals were refusing medical care to people who had medical debt, outstanding medical debt. And it reminded me that of some of the other work that Tzedek has done where, people owe fines or other debts to the government and they can't get a driver's license renewed, where you've done a lot of work in that area, or where they have licenses that they need for their occupations, a beautician or a barber, a plumber, and that it's kind of counterproductive to deny them an opportunity to earn a living, because they have this outstanding debt. So I guess I have two questions. One, isn't it counterproductive for these hospitals to turn away people who may otherwise be able to pay bills because they have outstanding debt? And is it lawful for them to turn away these people for who are in that position?
Yeah, it's definitely counterproductive. Preventive care is the most effective form of care we have, but that's unfortunately not required. By law, hospitals can't turn people away from their emergency department for inability to pay, but that's the only place where we have this requirement that they have to treat people. So unless you're going to the ER, they can turn you away from any preventive care or other forms of treatment that are more cost effective. And it's really unfortunate that you have to wait until it's an emergency to be able to get care you need, regardless of ability to pay, because that care is just so much more expensive for the whole system overall at that point.
Another question I had was when you were talking about the huge deferred interest for people who are offered these zero interest medical credit cards, and then they can't pay it off within the zero interest period. Are there efforts to attack that kind of practice as like predatory lending?
Yeah, there are. Senator Warren is actually really interested in addressing this. She wrote a letter to the CFPB urging them to take more action on this. Other nonprofits have urged the CFPB to take action as well, like Community Catalyst. There's actually comments are open right now until June 12th on their urge for the CFPB to do more to address medical credit cards. If anyone's interested to comment, it's on the Community Catalyst website. But a lot of groups are really hoping that the CFPB will do more to regulate these credit cards since they do have such a big impact on individuals and also community at large.
Are there efforts in state and jurisdictions or district also in that area?
Yeah, nothing in DC right now. I haven't actually seen any stories of patients. We haven't had any clients who've come to us with this issue yet, so we haven't been looking at it in DC specifically as much. But there are states, I think Colorado probably, for example, who are trying to do more to regulate medical credit cards at the state level.
One thing that really struck me when you talked about the statistics was that not only are residents in the Black community more likely to be sued, they'd be more likely to have bigger debts to pay off. So, aside from what are some of the explanations for that for that disparity?
I'd say systemic racism is probably the underlying issue. People of color are more likely to live in poverty, have minimum wage jobs without health insurance. Just the wealth disparity in that Ariel was talking about. People don't have the extra savings to pay off any unexpected medical bills. And so they're just really hit with higher bills and bills that they can't afford. They are also more likely to have chronic illnesses, which again, like I said before, is a really strong predictor of medical debt and leads to higher rates of
So the
medical
chronic,
debt.
so it's kind of compounds on itself. You're saying,
Yeah.
so you have somebody who has less money, they're more likely to fall to debt, they're more likely to not continue their medical care, and then they're going to have more expensive medical care as a result.
Yeah.
So that's why their bills are bigger.
Yeah. Yeah. Just a cycle of poverty that we've trapped people in. And that's why a lot of groups are interested in this as a form of reparations, trying to break the cycle and give them a clean start.
So, Vicky, you may have some questions.
There are a bunch of questions coming in.
Oh, okay, so why don't we take those?
Yeah. Yeah. So the first one is, what is the rationale for Maryland's prohibition on purchase of medical debt? I don't know how well I can be heard, so maybe go ahead and repeat the question when you answer.
We have another.
Oh, is this okay? Okay.
Yeah.
And can we just get feedback? Can people hear Vicky, or do people want a repeat of the question?
I got a yes.
So why does Maryland prohibit the sale of medical debt? Maryland has done a lot to address medical debt at the state level recently. I think their prohibition on the sale stems in part from trying to protect people from abusive collection practices. Since you can't sell to third parties, you're trying to limit the amount of collection calls that they get that other non-healthcare providers who are trying to collect debt are much more known for. I think it's supposed to also just, like, if only healthcare providers can collect on it, then you're potentially less likely to be sued over it if hospitals don't want to expend their resources to do so as well. I don't know. Do you have any other insight there?
I agree with all of that. The only thing I'll add is, best as we can tell, it's a well-intentioned rule that's in this regard overbroad and may have been passed without contemplation that there could be good guy medical debt purchases for these palliative reasons. And so it actually tees up, and I'll make eye contact with our JCRC colleagues, it tees up as a Maryland public policy issue for coming sessions.
Also, I'll say that some people some people are somewhat against the purchase and cancellation directly from healthcare providers because they see healthcare providers as a bad guy and think that they should have done more to prevent the medical debt in the first place. And so we shouldn't be giving them more money by purchasing the medical debt. But it's a penny on the dollar, if that, and it just has such a big impact on the patient that we think it's really worthwhile.
I just had to, when you mentioned viewing them as bad guys, the thing you mentioned about was one of those consulting firms recommending to hospitals, to not tell people that they had mechanisms to lower their medical debt or to avoid it altogether. Isn't that criminal? It's I don't know, criminal, but it's definitely illegal. And so there's actually investigations, I think specifically in Washington State, by the Attorney General's office and
looking
they got
into
paid
this.
for giving that advice.
Yeah, it's horrible.
So, Alyssa, it looks like you're off mute. I don't know. You had your hand up, and I'm not hearing you though. So if you want to try to ask your question. No. Are you there, Alyssa? All right, I'm going to move on to Anne Sloan asks, anecdotally, my observation of those most burdened by medical debt include, of course, people who lack health insurance, but also those who incur costs for uninsured care, especially dental care. Does RIP target specific types of care?
RIP doesn't target specific types of care. I don't know that they've worked with dental providers in the past. But they more so just target specific groups of patients who are eligible for their services. So they'll work with So for example, they'll work with a hospital and they'll purchase all the accounts of patients who are eligible for RAP services. So all the accounts for patients up to 400% of the federal poverty level, or their medical debt's 5% or more of their annual income, they'll just wholesale purchase all of that medical debt to be forgiven, to canceled.
And I'll just add, the question really tees up, is this about the what or the where? And RIP's focus has been about the where. So if the debt is held under whatever category of care was received, if the debt is held by the hospital, it's going to be a potential fit for the RIP philanthropic transaction. If the dental debt is held by, like your local dentist, so far at least, the RIP model has not extended to that. That doesn't mean similar either expansions by RIP or other innovative expansions in the future couldn't capture dental debt, but right now that's not sort of squarely within what's been done so far on the philanthropic side.
So it also wouldn't cover private care from private providers who are not operating out of a hospital. It's really only hospital based.
Right. And the only thing I'll add is one of the many reasons that all of the systemic solutions that Jennifer is teaching us about are important is because it's only through kind of a broad-based set of rules and policy changes that relief can come to kind of the full complicated range of fact patterns. Because, people have medical debt at their dentist or their local non-hospital doctor, or they have medical debt that's not actually held by any of those providers. They paid the provider in full, and now it's sitting on their Visa bill. And so it looks from a financial perspective like credit card debt, but it's really medical debt when you peel back the onion. And it becomes critical that our rules speak to sort of medical debt full stop. It's one of the many reasons why we're absolutely embracing everything you heard today about the purchase and buyback model as a Band-Aid, as a backwards looking remedial or reparations model, but it's equally critical that we get it right going forward. So like Jennifer said, we don't just end up back in the same place 2, 3, 5 years down the road.
So we have another question that asks, do you have a Know Your Rights resources on the topic that you can recommend and be shared with low-income community members throughout our network?
We have a flyer forthcoming, and we're just waiting on the Spanish translation for our website, and then we'll have a pretty detailed Know Your Rights on our website and a flyer in English and Spanish that we'll be able to pass out within our community.
Is that stuff that you can share with us? So
Absolutely.
when we send this recording around to people, we can include
definitely.
that. And what about the PowerPoint?
Yeah,
Okay.
for sure.
Because
Yes.
I noticed that some of the resources on the PowerPoint.
Yeah,
Or
all the
hyperlinks.
education is hyperlinked for people,
Great.
so I'll share it out.
Absolutely. So we should be able to circulate the hyperlink today to our JCRC friends who I think now have it. And then whenever the post-event blast goes out, it should come. And then if that happens before the Spanish translation is back to us, which is slightly beyond our control, but it's soon, we'll make sure to get it to JCRC for supplement.
Great. Oh, it looks like Alyssa might be back.
Hello? Can you hear me now?
We can.
Oh, good. I just wrote my stuff. I apologize. I'm having technical difficulties. I appreciate what I hear are Chicago originated participants on this call, but I'd like to say that I've been at this work for over 30 years. I'd like to know, and you won't have time for this, how your theoretical and policy information you shared today carries down to the actual grassroots one-on-one client services areas. For example, no offense, but there are 3 white faces sitting up there talking about Black debt. I'd like to know, for example, have you reached out to the NAACP, who has national offices in Baltimore? Are you working with other organizations like UNISA, the Latino-based group, to work with them so that the faces that provide the actual services mirror those who are seeking the services? And by the way, one of them could be me. I am presently in West Virginia, and I wear shoes and have all my own teeth. But the reality is that it can affect anyone, and I'm very sensitive to that. And I provide these services on the ground all the time. So I'd like to be actively involved with your group, even at the policy level, to provide testimonial information.
Alyssa, thank you for that question. We should start by saying yes. Please do. Please reach out to us. We would welcome your involvement. We would benefit from it. It really much. It sounds like you asked a really important question about why are there only white folks talking about this issue? It's critical, and I should say not all of our colleagues are white. That's important too, and a number of them lead both our direct services and our community outreach direct services in sharing in the community about medical debt and other issues. We know that's important. We share that view. You asked also about the extent to which we partnered with some of the national racial justice organizations. We have on other fines and fees and debt issues. With respect to medical debt, our work so far has been pretty intensely focused in terms of the DC reforms that you heard about earlier. That is very much included. That is very much included racial justice, anti-poverty, faith-based civic organizations in DC, and particularly if some of those efforts that Jennifer is alluding to get a little bit of traction at the national level. It's my deep hope that everybody from NAA to all the organizations comprising the Conference of Leadership and Human Rights organizations nationally would dive into this. We have partnered with the NAACP on several issues, and in my past life, I was outside counsel at the NAA. So appreciate both you're putting up your hand, and we'd like to accept that handshake for collaboration, but also the spirit of your question.
Okay, I would like to also mention I am a member of the NAACP here. I also speak Spanish and provided financial literacy education and resources in Spanish as well. So I defy the West Virginia stereotype, and I've put some notes in the meeting chat, but I would appreciate someone from your organization contacting me to kind of review with me how I can be helpful, with the understanding that I lived in the DC area, I lived in the Chicago area, I lived in the Maryland area, and now I'm in the poorest area of the country and have a very vocal senator. So if there's any way I can be helpful, I'm happy to do so.
Thanks so much. And I think
why don't you go ahead and, if you don't mind, putting the best contact information for you in the chat. You can put it directly to me, to JCRC, if you don't want it to go to everybody, but and then I'll make sure that Ariel, Jennifer get it.
Okay, thank you.
I have a question, which is a little bit not in the weeds in the same way that some of these other questions are, but wondering, with all the news, I feel like headline news about debt right now is about student loans. So I'm wondering if you can speak about that, either in terms of a comparison or just sort of how is that helping or hurting getting traction on these medical debt issues?
Yeah, good question. I think I don't know. I don't think it's hurting. I think, it's good to talk about debt, and it will be interesting to see what happens in the Supreme Court, because people have floated that if we can cancel student loan debt, we might be able to cancel medical debt the same way as a next step.
We the government,
yeah. The administration could do more. And so student loans is kind of a test run to see how far we can go with that. I think there is a lot more press on medical debt now than there used to be. Just within the past year, the whole NPR series on debt has come out, and they have tens of articles on it. A lot more research. So I would say ever since I started in September, there's just a lot more news coverage on it, and especially with more localities. I think there might be more coverage at the local level, especially around like what Cook County is doing and DC and places like that who are actively doing this work to cancel medical debt. But there's still a big contingency of people focused on it, and I think after the Supreme Court decision too, it might be more airtime for this issue.
Yeah, I agree with that. All of that, and I'll just add two things. One is that there's a somewhat common theme to your point about sort of the high level relationship. I think the student loan debate has brought out that so many people are kind of sold a bill of goods about that college is absolutely for everyone, that these investments and these loans, even at these sometimes high and problematic rates, are worth it for the American dream. And so even though they were, the narrative kind of emerges that even though these loans were taken on voluntarily, that there was a whole apparatus in place to make it very difficult to turn them down. That is close, not identical, but close to the kinds of arguments that Jennifer was educating on us on about medical debt is not optional, because when you have a health crisis, you go to the hospital. You have to, you should, we want you to. So there's an interesting through line there. The second thing I'll say is one difference, and I think this is just why the focus of the conversation is in slightly different places, is that yes, the federal government, as Jennifer alluded to, can be a market actor in medical debt, and there are federal hospitals and the federal government can set rules. But unlike the student loan market, most of the medical debt is held by private hospitals. In the student loan context, the vast majority of that debt is held by the feds, by the Department of Education. There is a less than 20% market held by private loan services for student debt, and so it's sort of a in many ways a more dramatic question about student debt, because it's all about the government and whether the public is going to forgive or not. And this in the medical debt context, for the most part, we're talking about the government's role being setting the rules and making sure we get to a better place.
Also, as Biden said, he's not going to sign Medicare for all, and so it's it's kind of a non-starter for a lot of policy work to like truly address medical debt.
Somebody commented that the legislation, such as the No Surprises Act, should help prevent people from accruing medical debt going forward.
Mm-hmm.
Yeah, definitely a good step. I don't have to say more.
Yeah. The No Surprises Act specifically, like for out-of-network care, so you shouldn't be given surprise bills for anything related to that. It does have some limitations. I don't think it covers like ambulances or things like that. But it's definitely another tool for people to try to challenge their medical bills.
People have said thank you for a very interesting conversation.
Thank you.
Yeah, well, I want to thank both of you. And for those of you in the audience who know of people who wanted to attend today but couldn't, we'll have a recording. The JCRC of Greater Washington has a YouTube channel, and it has a lot of past Brown Bag and other programming that's available in the recording. And I think we'll also make available the slides that you presented today. And so there's some really valuable information that you can share with others that weren't able to participate today. We really want to thank you very much for all the ongoing important work that you do